The major byproduct of metabolism is carbon dioxide that turns into carbonic acid and bicarbonate in the blood. A huge component of acid-base chemistry is how we handle carbon dioxide. If it accumulates, we have an acidosis known as a respiratory acidosis. If we are tachypneic and we breathe too hard, we get alkalotic or respiratory alkalosis. This can be acute or chronic. So this tutorial is about carbon dioxide and bicarbonate. The fizz of carbon dioxide. This is the second tutorial on acid-base chemistry, and in this tutorial I'm going to talk about carbon dioxide, bicarbonate, and why they are so important in acid-base balance. Previously I discussed hydrogen ions, the definition of acids and bases, the pH scale and how it relates to the hydrogen ion activity, the concept of neutrality, the impact of temperature on pH, the terminology of acidosis, alkalosis, and the concepts of respiratory and metabolic acidosis and alkalosis. This time I will discuss carbon dioxide chemistry and production, acute respiratory acidosis, chronic respiratory acidosis, and acute respiratory alkalosis. Let's start with a clinical scenario. Imagine that you're an anesthesiologist and you're in the operating room and you have a 24-year-old male having elective surgery. Following induction of anesthesia, the administration of neuromuscular blockade and intubation, you forget to turn on the ventilator. 10 minutes later, the desaturation alarm goes off. So this patient has had no ventilation for 10 full minutes. And now they're beginning to desaturate, having been pre-oxygenated prior to induction of anesthesia. If immediately after restarting ventilation you were to measure the pH, the PaCO2 and the end-tidal CO2, what would the measurements be? Well, let's look at carbon dioxide. At all temperatures on the face of the earth, carbon dioxide is a gas that can only be liquefied under pressure. The critical temperature for carbon dioxide is minus 31 degrees Celsius. Physiologically, CO2 is always a gas, and it obeys Henry's law. Gases dissolve in liquid. The amount of gas that dissolves was described over 200 years ago by William Henry, and it is determined by temperature and pressure. The higher the pressure, the more carbon dioxide that dissolves in the liquid. In the body, that means that the total quantity of CO2 in blood is proportional to the partial pressure, the PCO2, and this is why the PCO2 is so useful in the blood gas. It gives you an idea of whole body CO2 content. It means that the more metabolic activity, the greater the PCO2 in blood, and if the body fails to clear CO2 effectively, the PCO2 will continue to increase progressively. So we know that our patient who is apneic for 10 minutes will progressively generate a higher and higher and higher PCO2. But wait, there is more. Lower the temperature of the body and you increase the amount of carbon dioxide that dissolves in blood. And that's because the solubility coefficient for gases increases with lower temperature. So a hypothermic patient will have more CO2 dissolved in their blood and in their extracellular fluid than a normothermic patient. And a hyperthermic patient will have a lower CO2 because less gas dissolves in warm blood. And you know this. Carbon dioxide is more soluble in colder liquids. If you open a bottle of soda and you leave it on the counter versus putting it in the fridge, the soda that's on the counter is less fizzy after an hour or so. We also know that melting ice caps are releasing carbon dioxide, and if you boil a pot of water, as the water heats up, it starts to bubble out. If you attach IV fluids to a fluid warmer and watch the fluid coming out of the fluid warmer, you'll see little bubbles of air coming out. And that's because warmed liquids can hold less gas. Based on our previous tutorial, we now know two things about blood as it's cooled. The pH rises because of less water dissociation, but the PaCO2 falls because carbon dioxide is less soluble, so less carbon dioxide is released from blood or extracellular fluid into the blood gas machine. Because of the complexity of what's going on here, the easiest way for a bedside clinician to assess a blood gas with these changes in temperature is for correction of the temperature to 37 degrees Celsius. And this is known as the conventional or alpha-stat approach to blood gas interpretation. And this is the only approach that I'm going to discuss in this course. Effectively, you must correct the PCO2 and the pH to 37 degrees Celsius. You input the patient's temperature and the machine makes the corrections. Along the CO2 pathway from the mitochondria to the mouth, there is a gradient of about 10 millimeters of mercury or 5 kilopascals. The CO2 goes from the mitochondria to the venous blood, to the alveoli, to the dead space, to the mouth. When we are measuring PaCO2, we usually do that from a blood gas where the pulmonary vein CO2 is about 40 millimeters of mercury or 5.2 or 5.3 kilopascals. On the venous side, it's slightly higher. Remember, that's the pulmonary arterial CO2. It's about 44 millimeters of mercury or 6 kilopascals. So depending on whether you do a venous gas or an arterial blood gas, the partial pressure of CO2 is going to be slightly different. Conventionally, and in this course, we use the arterial number. And there's about a 3 to 5 millimeter of mercury or 0.3 kilopascal difference between the end tidal CO2 and the arterial CO2. And that's why we are able to assess the partial pressure of blood CO2 based on the end expiratory CO2 because it's usually in equilibrium in the majority of patients. The body will always try and restore the PaCO2 to around 40 millimeters of mercury or 5.3 kilopascals regardless of the production. Baseline production is about 200 mils per minute and baseline excretion is therefore 200 mils per minute. That can increase exponentially in hypermetabolic states such as running a marathon or sepsis or acute critical illness. And so the way the body deals with this is the respiratory rate and tidal volume, the alveolar ventilation, increases to blow off CO2. And that's why when you start jogging, you start to breathe more frequently and more deeply. And it's a very effective system. And the PCO2 generally stays in and around that 40 millimeters of mercury range. Remember that CO2 is produced by cellular metabolism. It then diffuses across the cell membrane that is freely permeable to carbon dioxide. Some of that carbon dioxide dissolves in the blood. Most of it enters the erythrocytes, that's the red blood cells, where it's hydrated with water in the presence of carbonic anhydrase to carbonic acid, and that ionizes immediately to release bicarbonate, and the hydrogen ion, or the hydrogen ion clump of water, is bound to hemoglobin. So hemoglobin is the major extracellular buffer for carbon dioxide. The bicarbonate then diffuses out of the cell and it's swapped for chloride in a process that's known as the hamburger shift. If you look at the quantity of carbon dioxide in the blood at any given time, only a small proportion is dissolved as gas. About a third is bound to hemoglobin, that's carbaminohemoglobin, and 2/3 exists as bicarbonate. It is imperative that you understand that plasma bicarbonate rises in direct proportional to CO2. It is not some form of renally associated metabolic compensation. That is achieved by wasting chloride in the urine, and that increases plasma strong ion difference. Bicarbonate is CO2. Carbon dioxide and bicarbonate are the same thing and their concentrations always rise and fall synchronously. Now that we know about total CO2, one must understand that the partial pressure of carbon dioxide can change rapidly when there are changes in alveolar ventilation. In this model from Nunn's Respiratory Physiology, we can observe a patient who has a PaCO2 of 44 millimeters of mercury or 5.3 kilopascals and is receiving 3.3 liters of minute ventilation. Now watch what happens when the minute ventilation is increased to 14 liters. Look how quickly the PaCO2 drops down below 20 millimeters of mercury or 2.5 kilopascals, receiving that 14 liters of minute ventilation. At this stage, we're going, well, this is a big mistake, obviously, so we need to reduce the minute ventilation back to 3.3 liters per minute. What then happens is that the CO2 builds up, but it builds up way more slowly than it came down. And the reason for this is because the CO2 is only produced at 200 mils or so per minute. So increasing the minute ventilation rapidly clears extracellular carbon dioxide, and that reduces the partial pressure of CO2. But once the minute ventilation is reduced, it's much more slow for CO2 to build up, and this is quite predictable. So CO2 is replaced by metabolic activity. It just doesn't build up as quickly as it goes down. I think it's important to understand that if you make a ventilator change and you're following carbon dioxide, if you just check the blood gas at 10 minutes after you've adjusted the ventilator, it may give you quite a misleading level of carbon dioxide because you don't know where that patient is on the curve. You really have to wait till it settles down at a plateau for that particular minute ventilation. And that brings us back to our patient who is apneic for 10 minutes. How much carbon dioxide do you produce in 10 minutes? And this is what happens to the partial pressure of carbon dioxide over time. It rises by about 10 millimeters of mercury or 1.3 kilopascals in the first minute, and then it rises very predictably by 3 or 4 millimeters of mercury or 0.5 kilopascals every minute thereafter. 12 millimeters of mercury in the first minute, 3 to 4 millimeters of mercury per minute thereafter, so that after 10 minutes, the PaCO2 will have risen by 44 millimeters of mercury or 5.8 kilopascals to a total of 84 millimeters of mercury. The PaCO2 to end-tidal CO2 gradient is normally 4 millimeters of mercury or 0.52 kilopascals. So immediately after switching on that ventilator on this apneic patient for 10 minutes, the end-tidal CO2 will be 80 millimeters of mercury or 10.5 kilopascals. What I want you to remember is that in apnea, the PaCO2 doubles in 8 minutes. Now, let's move on to talk about respiratory acid-base abnormalities. I want to make a point that regardless of where you come from on the acid-base spectrum of understanding and what school you were taught by, everybody agrees on what I'm going to tell you about respiratory acid-base disorders. Now, this is a very busy picture. If you look at the history of acid-base, there are two major schools of thought on this. The electrochemical school, starting with Henderson and Van Slyke to Singer and Hastings to Peter Stewart, that look at the electrochemistry of blood and figure out acid-base abnormalities based on that. An example of the electrochemical school would be the anion gap or the strong ion gap. On the other hand, there were two schools from the 1950s, Boston and Copenhagen, who developed the concepts of the rules of thumb with carbon dioxide and bicarbonate, and later the base excess and the base deficit. Irrespective of which school you are part of, everybody agrees that changes in the partial pressure of CO2 are associated with acid-base abnormalities. And what I'm going to go through in the rest of this tutorial is the Boston School approach to CO2, which I think is the easiest one to understand and it's really broadly applicable. I'm going to start off with respiratory acidosis. Our patient who is apneic for 10 minutes, who is hypercarbic, will have developed an acidosis. That means the pH will have fallen. How does that increased partial pressure of CO2 in arterial blood translate to an increase in the hydrogen ion activity and fall in the pH? Well, Brackett and Schwartz and colleagues back in the 1960s were able to map a direct correlation between the increase in the hydrogen ion activity and the partial pressure of CO2. And that makes this mathematically very easy to demonstrate, because a rise in the PaCO2 results in a very predictable rise in the hydrogen ion activity and a fall in the pH. And as you recall, a 1 nanomole per litre or 1 nano equivalent per litre increase in the hydrogen ion activity results in a 0.01 fall in the pH. Now, I'm just going to show you a little calculation. Don't be scared by this because it's really easy. That change in the hydrogen ion activity in nano equivalents per litre equals 0.8 times the change in the partial pressure of CO2 in millimeters of mercury. So looking at our apneic patient for 10 minutes, if the PaCO2 rises from 40 to 84, that results in an increase in the hydrogen ion activity by 0.8 times 44. The difference is 35 nanomoles or 35 nano equivalents per litre up to 75 nanomoles or nano equivalents per litre. This results in a fall in the pH by 0.35, so his pH will be 7.05. And honestly, that's a little bit scary for anesthesiologists who often let their patients breathe spontaneously at the beginning of the case, and they hypoventilate for quite a while before ventilation is established. And sometimes the end-tidal CO2 can be 55, 60, maybe even 70 millimeters of mercury. Be aware, when that end-tidal is that high, the pH has fallen considerably. Let's move on and look at the actual bicarbonate. I'm calling this the actual bicarbonate because this is the number on the blood gas you should be paying attention to. But it's sort of a neologism, just like calling air room air. Air is air. It always is air. Bicarbonate always is bicarbonate. So let's look at another patient. Now, her name is Nora. She's 46 and she's 8 hours post-abdominal surgery. And at the start of surgery, her end-tidal CO2 was 40 millimeters of mercury. She had a GA, an endotracheal tube. She got morphine intra-op, is on a morphine PCA. And back in the recovery room, she's very sleepy. She's snoring and her saturation drops to 88%. When we measure her end-tidal CO2, a tight-fitting mask is put on with a CO2 monitor on it. Her end-tidal CO2 is 76 millimeters of mercury, or 10 kilopascals. Now, I've shown you how you can figure out what her pH is and her hydrogen ion activity is. But what is the blood concentration of bicarbonate in this patient? I'll just give you these data. You can see here that her pH is 7.08. Hydrogen ion activity 72 and PaCO2 80 based on the previous calculations. But I want to know what our bicarbonate is. I've also shown you our sodium, potassium, and chloride just so that you know that these are normal. So what do you think her bicarbonate is? Is it 22, 24, 28, or 32? Well, let's work the problem. It's important to understand that blood gas machines do not measure bicarbonate, they calculate it. The lab can measure bicarbonate, but the result is usually indistinguishable from the calculated version. And on the blood gas report, 2 versions of bicarbonate are reported. The actual bicarbonate, which can come up at HCO3 minus with a little C after it, or a C HCO3 PC after it, or the standard bicarbonate, which I'll mention in a few minutes, but I will point out that most clinicians do not use the standard bicarbonate in this day and age. And how bicarbonate is calculated out by the blood gas machine is using the Henderson Hasselbalch equation. Even though you're now clearing the vomit from your mouth at the thought of this equation, let me tell you that this is a cool equation. It's much misunderstood, a bit like the Bee Gees. It's a classic that keeps on giving. And to calculate out Nora's bicarbonate, you just need to use the equation. So this is our Henderson Hasselbalch equation that's causing that severe nausea that you're feeling right now, because this has been shown to you ever since you started in college. But it can be reworked in various ways, and this is quite a nice way to rework it. So we have our bicarbonate concentration is 0.3 times the PaCO2 times 10 to the power of the pH minus 6.1. And that's easy. You can do this on your phone in seconds. So in Nora's situation, we have 0.3 times 80 times 10 to the power of 7.08 minus 6.1, which is the ion dissociation constant for bicarbonate, which I'll discuss in the next tutorial. And if you'll work this out, Nora's bicarbonate is 28 millimoles per liter. So the correct answer is 28 millimoles per liter. I am not going to ask you to do this on every patient that you're trying to figure this out on, because there's a really nice rule of thumb, and this is it. For every 10 millimeter of mercury increase in the partial pressure of carbon dioxide acutely, that's 1.3 kilopascals, there is an increase in the bicarbonate by 1 millimole per liter. And again, this came from the wonderful work by Brackett and Schwartz and Cohen back in the mid-60s. And you can use this anytime very simply without having to resort to Henderson Hasselbalch. But I think just once you should do it. So if you look at the changes in bicarbonate and PaCO2 in acute hypercarbia, we can look at Nora here. Her hydrogen ion activity, 72. Her PCO2 has gone up by 40 millimeters of mercury, and her bicarbonate has gone up by 4. That was easy, wasn't it? I'll give it to you again. In acute hypercarbia, the bicarbonate rises by 1 millimole per liter for every 10 millimeters of mercury, or 1.3 kilopascals increase in the PaCO2. And of course, the pH falls by 0.08. Let's look at another patient who's at the pre-clinic. And this is Philip. He's a smoker, and he's arrived at the clinic, and all you have is a chemistry panel. And on this chemistry panel, there are 2 abnormalities. Can you spot them? Well, here they are. The abnormalities are high bicarbonate. The normal bicarbonate is 24 millimoles or 24 milliequivalents per liter. And the normal chloride is somewhere between 102 and 105 millimoles or milliequivalents per liter. In Philip's case, his chloride is really low. And these 2 abnormalities and the balance between them are not coincidental. The chloride is low because the bicarbonate is high. So in Philip's case, the bicarbonate is high, and that means that his partial pressure of CO2 in his blood is high. And this is not acute. This is likely going on for ages because he's just rolled in off the street, and his body has had a chance to compensate. Now, Philip likely has COPD. Here's a question. If you're the anesthesiologist, at what level should you target the end-tidal CO2 intraoperatively, assuming that 4 millimeters of mercury below the partial pressure of carbon dioxide is where the end-tidal CO2 should be, to make sure that his intracranial blood flow is maintained? Remembering that if you hyperventilate a hypercarbic patient, they develop a relative alkalosis and they become vasoconstricted. Should it be 40, 46, 56, 66, or 76 millimeters of mercury? For this, and to answer this question, there's a really handy rule of thumb as well, developed by Brackett and Schwartz and colleagues. In chronic hypercarbic respiratory acidosis, an increase in the partial pressure of CO2 by 10 millimeters of mercury, or 1.3 kilopascals, results in an increase in the bicarbonate concentration by 3 millimoles or 3 milliequivalents per liter. So a little bit different from the acute situation, much more bicarbonate because it's had a lot of time to accumulate. So lots more carbon dioxide as bicarbonate in the blood. So let's work Philip's problem. He's 72 and his bicarbonate is 36. The normal bicarbonate is 24, so the difference between his bicarbonate and the normal is 12 millimoles or 12 milliequivalents per liter. And using the rule of thumb that a 3 millimole increase in the bicarbonate for every 10 millimeters of mercury increase in the partial pressure of CO2, we can figure that out at 12 divided by 3 multiplied by 10 equals 80 millimeters of mercury, or 10.5 kilopascals. And that's pretty impressive. And that means that ideally in the operating room, you should be targeting an end-tidal CO2 of about 76 millimeters of mercury. You may choose not to do so, but this is where Philip lives. And so this is a table that you can freeze if you like about the changes in the bicarbonate versus the PCO2 in chronic hypercarbia. This is where Philip is. This is what his PaCO2 likely is. 80 millimeters of mercury for 36 milliequivalents or millimoles per liter. I'm going to say that again. Chronic hypercarbia, the bicarbonate rises by 3 millimoles per liter for every 10 millimeters of mercury, or 1.3 kilopascal increase in the partial pressure of CO2, and importantly, the chloride falls by an equivalent amount. Now, I'm just going to mention the standard bicarbonate because some clinicians use it for various reasons in the ICU. I'm not going to tell you how to use it, I'm just going to mention it now. This is a 1950s era calculation that is done by every blood gas machine, and it derives a standardized or normalized bicarbonate that assumes that the PCO2 is 40 millimeters of mercury, the PaO2 is over 100, and the temperature is 37 degrees Celsius. Now, this was superseded by the base excess, but some clinicians use this as a way of determining whether the patient has acute and chronic respiratory failure, and we may visit this in a later stage in the course. Let's briefly look at acute respiratory alkalosis. Here's a scenario. Steve is 22 and he comes in for a knee arthroscopy. He has a panic attack in the holding bay and becomes dizzy and loses consciousness, and you check a blood gas. His pH is greater than 7.4 and his PCO2 is 30 millimeters of mercury, or 3.7 kilopascals. In this setting, what will his bicarbonate be in millimoles or milliequivalents per liter? Is it 24, 14, or 22? The correct answer here is 22. And there is a nice rule of thumb for this as well. Primary respiratory alkalosis is caused by pain, agitation, anxiety, delirium, and brain injury. And in this setting, the change in the bicarbonate is 0.2 times the change in the partial pressure of CO2 in millimeters of mercury. So in this setting, the bicarbonate is 0.2 times 40 minus 30, and that equals 10, or 22 millimoles per liter. That is a very small drop in the bicarbonate from 24 to 22. And despite this patient having a respiratory alkalosis, there are situations where that pH may be much closer to 7.4, maybe below 7.4. And it's important to understand that in metabolic acidosis, that bicarbonate level will be much lower, because in that situation, the bicarbonate falls because it acts as a buffer. In this situation, the bicarbonate has fallen because bicarbonate is CO2 and the patient is hyperventilating. Let's review this tutorial. In this tutorial, I discussed carbon dioxide production and chemistry. Carbon dioxide is the most important acid in the body. Then I went through a number of perioperative clinical scenarios because these patients are really clean and it's very easy to explain these in that controlled setting. The first was a case of a patient who was apneic for 10 minutes, and we looked at acute respiratory acidosis and how you can figure out the pH, the hydrogen ion activity, the PCO2, the Untitled CO2, and the bicarbonate from very simple numbers. I then went to explain what happens in chronic respiratory failure. Principally, the bicarbonate goes up and the chloride goes down. And finally, we looked at acute respiratory alkalosis. And we looked at the change in the bicarbonate, which falls with the increase in the alveolar ventilation and the fall in the PCO2. Next time, we're going to look at ionic charge and valency and why this is important in acid-base chemistry. And I'm going to look at the dissociation equilibria and pKa for ions, and we're looking at strong ions at the end of that tutorial. Join me then, and I guarantee you'll learn something. So that was all about carbon dioxide and bicarbonate. I hope you found it useful. Next time we're going to talk about ions and the pKa. If you're enjoying these tutorials, subscribe on YouTube or follow me at ccmtutorials.org.